Welcome to Coping with COVID-19. I'm Dr. Allie Sharma. This interview series is a safe space to collectively cope and share our stories through the COVID-19 pandemic. Quick disclaimer, please note that this interview series is for informational purposes only, and it's not considered medical advice. Please consult your own provider for any issues you may be facing, and if you are in crisis, please call 911 or your local emergency services. Today, I'm honored to be joined by Dr. David Henderson. Dr. Henderson is a psychiatrist leader and currently serves as Psychiatrist-in-Chief at Boston Medical Center. He's a professor and chair of psychiatry and assistant dean for diversity and inclusion also. Dr. Henderson serves as co-director of the NIMH T32 Boston University Medical Campus, Mass General Hospital, Global Mental Health Clinical Research Fellowship. He previously served as director of the Chester M. Pierce, MD, Division of Global Psychiatry at Mass General, director of the MGH Schizophrenia Clinical and Research Program, and medical director of the Harvard Program in Refugee Trauma. He is a community psychiatrist and has worked in a community mental health center for 25 years, caring for and conducting research with the seriously mentally ill population. He has worked nationally and internationally for the past 25 years in resource-limited settings and areas impacted by mass violence, disasters, and complex emergencies. In addition, he has focused on mental health capacity building programs and skill transfer programs for specialized and primary healthcare professionals in the greater Boston area and in several countries. In the United States, he has conducted more than 30 randomized clinical trials in seriously mentally ill populations to understand and improve psychiatric and medical health outcomes. I am bringing Dr. David Henderson to join me now. Okay. Hi, Dr. Henderson. It's so nice to see you. Thank you for joining me on Coping with COVID-19.
Good morning. Thank you for meeting with me today.
Yes, honored to have you. So first, I wanted to ask you how the pandemic has impacted your work professionally with the population that you serve in Massachusetts. And I'm thinking, both of the work you do as a safety net healthcare system, but also for severely mentally ill.
Yes, that's a great question. I think first of all, everything has changed. We had to take our typical system of care and turn it upside down and introduce new ways of helping patients. And in particular, as many places around the country have had to do this, we had to really switch to telehealth in order to best address our patients. Now, as a safety net hospital, of course, we have patients from all over. We treat patients from 80 different countries who all have different views of what healthcare is and healthcare delivery is. And of course, we've always had one system of care, and we expected patients to fit in that system, recognizing that there are populations that we weren't really addressing as a result of that system. And so with the result of the COVID-19, we've not only had to try to figure out how do we care for our patients that were coming in, but also how do we connect with patients who weren't engaging in care, but really needed help. And so we've developed a combination of a small percentage of in-person visits, particularly patients with severe mental illness, who, for instance, may not be comfortable with the technology that we were introducing, but also they need very, very specific treatments within the hospital, such as their monthly injections and things like that. And then we had to develop, really in a matter of 2 days, we had to convert from 100% in-person visits to about 90% telehealth visits.
Oh my goodness. And did you guys have the technology in place to do that?
Well, we had already started some telehealth, really to help our accountable care organization partners who had a minimal mental health capacity. And so we had already been in the process of doing that. And so that helped quite a bit. But then the other side is that none of our providers are really trained in telehealth nor comfortable with it. And so we really had to not only convert all of those appointments to telehealth, but then we had to train our providers in how to do it. And as you know, that we still don't, it hasn't been well studied as to what is gained and what is lost from a
Right.
telehealth visit versus a in-person visit. We know that there are differences, but you know, and I think over time we'll come to fully understand that. So we converted all of our visits, and what was remarkable in that process, we really learned a lot. That instead of having a, say for our therapist, a 45% no-show rate, that dropped to between 10 to 15%.
Wow.
Just yeah, very,
Incredible.
but insightful, because again, we had one system that you make your appointment. If you don't make it, you'll be rescheduled and so on. But what we learned is that patients pick up their phone. They answer their phone. Anytime they call, they pick up, and that really gave us access to our patients in ways that we hadn't thought before.
So telehealth doesn't necessarily have to be video. It can be also telephone, which then expands the possibility of access, I presume.
Absolutely, and I think our providers probably prefer the video because it's nice to see people.
Right.
But for many patients, the phone is adequate. It may not be adequate for every appointment with them,
Mm.
but it certainly can be, in the future, can be a part of their care.
Okay. Now, I would love to hear more because in the different interviews that I'm doing, I think there's a lot of unanticipated innovations and a silver lining that can come out of this period of transitioning to virtual work and a period of adversity. Um, what other things have come out of this so far that you didn't anticipate as a leader? So telehealth is one.
Yeah, I mean, I think, in addition to the telehealth, or a component of telehealth is also, it helped our providers as well. Uh,
Hmm.
we kept them safe, which I think was a critical component. We wanted to continue to help people, but we also had to keep our providers safe, and so that helped. There were, most of the providers worked at home,
Hmm.
which also, was positive and negative, perhaps. In the sense of, positive, they didn't have to commute, but negative in that they still were in their home environment and they still had to deal with things. The kids were home and the pets were home, and things like that. So that, people have, had to figure out a flow of their day and to how to be, effective in their work, while also recognizing that there are some challenges in their home environment as well. But headed, going into the future, again, we have to think about, is this a potential mechanism to help people with burnout? Because as you know, in mental health, in medicine in general,
Hmm.
the burnout is pretty high.
Yes.
And so, trying to, do that work-life balance. I think, every organization is trying to figure out solutions to improve people's well-being. And so this may become a component of that as well. So, which is very helpful.
Yeah, and I'm just curious because I know you have a research arm and research is very important for you. Are you guys thinking about, or are you tracking, or somehow monitoring these differences? And are you going to study this in some way?
Yes, we're doing it with our staff. We're
Okay.
certainly looking at it, and my particular interest is, and we're just, figuring out how to study this, but um, comparing a in-office visit with a phone or even video conferencing visit, my hypothesis is that, at least early on, that our providers are probably less aggressive in addressing patients' concerns, needs, symptoms, and so on,
Mhm.
changing medication, that sort of thing. But I think over time, people will become much more comfortable with this, and this will be, it's psychiatry in the 21st century, at least a component of it.
Exactly. And hopefully the regulations and insurance companies and reimbursements will catch up with this fully.
Well, I mean, that's a critical piece,
Mm,
because although we're still struggling with, the regulations are changing every day, the billing codes are changing every day, and so on. We're still struggling with, what are the right answers.
yeah.
But but if insurance companies continue to reimburse at similar rates that they're doing now, then this will make this stick. And not only that, it really greatly increases access to care, and
Yes.
that's been a huge problem here in the U.S., of course, and globally as well. But that increasing access to care, I think, is critical. And we've been able to demonstrate with our shift to telehealth that, in fact, we were able to reach more people. In fact, we had a referral list of about 1,400 people, on top of all of the patients we were already caring for. And then, in a matter of like 6-7 weeks, we were able to get that down to 400.
Okay.
Um,
Wow. Yeah, so look, it's really good to hear because especially for the populations that you've supported, right, both globally as well as what you're doing now, it is a vulnerable population, and increasing access is so important. And I wanted to build on that because there's a lot of discussion now about racial disparities and health disparities. So I would love to hear your observations about, the added layer of COVID-19 atop already vulnerable populations and pre-existing health disparities.
yeah.
What are your thoughts and concerns? What have you seen so far with respect to this?
Well, I think the COVID-19 pandemic really has, I guess, once again brought to light the incredible disparities in this country, and which impact health and mental health.
Mm.
And so, we were challenged at our hospital, because I would say maybe 4 weeks ago, we were at the brink, where we were close to being out of ventilators.
Oh, wow.
Um, and being a safety net hospital, we take care of a large portion of Boston, the minority population, Black and Latinx, and many immigrant populations, as well.
Mm.
And so, as you know, with all of the recommendations to reduce the spread of COVID-19, these populations are less able to follow those recommendations, and much of that is based on, economic disparities and housing and food security, and a whole bunch of factors that, prevent them from being able to work at home on a computer,
Right. Social
and separate.
determinants, right? All, yeah.
Yeah, exactly.
Mm.
And so that being said, so we have this, high risk population who also come with, tremendous amount of higher medical risk, like higher rates of diabetes and hypertension and renal disease and asthma. Again, much of it related to their environment,
Right.
and access, and so on. So we had this high risk population, and then, when it comes times to make decisions as to who gets what treatment, there's the crisis standards of care that are implemented, and that which have been done by, I think, many states. And we're following guidelines from certain models, to basically, determining, projecting life expectancy, and then determining who gets the ventilator, for instance, who gets those resources. And in the U.S., we're not used to doing that. We're not used to having to make those kind of decisions for the most part, and so, but this raised some huge issues because all of the models that are put together, are primarily based on, kind of fuel the disparities that we see. So the models, will penalize you for having diabetes, will penalize you from having renal disease, hypertension, cardiovascular disease, asthma, and so on. But our populations are at higher risk for all of those things.
Mm.
So um, it was quite a challenge, and we had to put together a huge committee with specialists in every area, and including individuals who are interested in equity.
Mm.
We stopped talking about disparities. We talk about equity. How do we give people equal playing fields? And
Mm.
so we had to redesign these models in order to not penalize and double penalize for conditions that are higher in one population versus another. But it was quite interesting.
Yeah, it's so interesting because you would think where there's more comorbidities, right? That could be mental and physical health. Those are the higher utilizers of our healthcare system. You would think the emphasis would be there. I'm thinking that way. Perhaps that's a social justice and, different perspective. That seems common sense to me, but it's interesting to hear what you're saying.
Yeah, it's very interesting, and yeah, I would think the same way. But I guess we're probably like-minded in this.
Right.
Um, you know, um, but you see examples of it. Like I think I saw a paper in Spain, for instance, and it was just casually mentioned that individuals with developmental disorders, adults with developmental disorders, were not eligible for ventilators.
Wow.
And so the government simply made the decision, it's a public health decision, but they literally, again, it was just mentioned very casually in this article,
Hmm.
and I thought, oh my God, this is just unbelievable.
Yeah, that sounds like a form of discrimination.
Yeah.
Yeah. Wow. Okay. And so, look, I know we spoke about this briefly before, but you're talking about operating with a lower than ideal number of resources, right? Which is something you've done in low and middle income countries and other contexts, and rationing, right? Which is something that other healthcare systems have to do or do as part of healthcare delivery. So can you comment on that? Because I'm sure it then you draw from your global and your local experiences, right? To think about this complex issue.
Yeah, this is it was eye-opening to me. I guess maybe once again, in a sense, like I've been involved not only in global work but also in disasters, natural or man-made disasters, post-conflicts, and so it's very typical to have a limited amount of resources, to have individuals that um, that could be saved, to watch them die because of the lack of resources. And so some of my global colleagues, they deal with this every day. They, in each place, of course, has, I guess, approaches as to how they make decisions, but oftentimes, but it occurs on a daily basis. Now, I think that what we have seen here with our pandemic is that, first is, the US is not really prepared for things like this. So we have no practice in it.
Mm.
And when they come up, it's just some awful stuff. I'm reminded of when I did some work around Hurricane Katrina. And, and I think that really highlighted to me how, a country with such wealth and resources um, is really not prepared to handle things like that.
Mm.
And we saw that with Katrina. We see this with the pandemic, where we should have been able to be on top of this, kind of much earlier on, to the point where we didn't have to start thinking about who gets ventilators and who did not.
Right. And I think also, like I've talked to a lot of people that work in international development and are doing global response, for example, to Ebola. contact tracing was just an immediate thought, right? And here it felt like it was an afterthought. So I
Yeah.
agree with you. I think there's something about the lack of practice and working in this kind of disaster crisis mode that has maybe impacted the response,
Right.
the
Exactly.
preparedness around the response.
Yeah, and it affects the American people too. You know, like with Ebola, like I was impressed. I've done a lot of work in Liberia, but they really had to change a lot of cultural practices in order to shut the epidemic down.
Mm,
Things like um, touching and that sort of stuff. But taking care of family members, like when someone dies, they keep the body in the home for 5 to 7 days, and there's something happens every day, and people come and they
um,
pray and they hug and all of this stuff, and they literally had to change all of those practices in order to stop the epidemic. And we, and of course we've done a lot of change here in the U.S. as well.
yeah.
And I think that you're not wearing a mask, I'm not wearing a mask, but when I go outside, I imagine I'm going to be wearing a mask for months, if not a year or two,
Yes.
um,
Yes.
until we get through this.
Yeah, exactly. So, what do you think in terms of the physical distancing? What has the impact been on the communities and the populations that you work with? And the caveat or the twist, I say this because, I think about vulnerable populations and how community-based interventions and social connectedness is an intervention, right? And
Yeah,
yet now we're not allowed to do that. So,
yeah,
what do you think the impact has been?
yeah. I think the first thing they came out with the wrong phrase. They said social distancing. It's physical distancing. That's because we want social connectedness. And I think young people may be better suited at this because I know my kids are on the phones chatting with people in groups of 10, 20, 30, like all the time.
Mm,
So they may be better suited for this, but in truth, the impact of this we're going to be feeling for months or years to come. I
mm,
think that we probably will see an increase in suicide, and in we certainly have had cases now that we would not have expected before.
okay.
um, and I think that people will the rates of anxiety and depression will kind of increase significantly
Mm,
as a result of this as well. And then people are isolated, and human beings, I think most human beings really like to be around people. Um,
yes.
it's what makes it life great. But then we have really vulnerable populations, and so this is even more so. Individuals with severe mental illness, elderly in particular. So these populations are actually much more vulnerable, and their risks are greater. And so that we're going to see some bad outcomes if we haven't already in these populations. And and some of them may not have the technology available to um, to utilize this social connectedness through their phones and apps and that sort of stuff.
Exactly. So, just to switch gears a little bit, from your vantage point, you as a leader in psychiatry, but having done work in complex emergencies, let's say, what are your ongoing thoughts, fears, concerns about this pandemic? Just thinking about it existentially.
Well, I think typically, mental health is the last thing people think about, but it's probably the most lasting negative thing that comes out of it. And so I think that we're going to not only with those who already had a mental illness and so on, we're creating a whole new population of people who prior to this had no mental health concerns, and now will start to slide into individuals that really need we care. And so so my concern, of course, is that will we have the capacity to care for these individuals and to get them back to work? And we haven't even talked about the economic impact on mental health.
Right.
But will we have the capacity to help people to get them functional again? And again, this will go on for months or years, and so that's my biggest concern. And so I think I'll, and even more so, if you think about first responders, the healthcare workers, and so on. So it's a whole nother group of individuals that will have lasting effects from this pandemic. And
Yeah.
then the third group is individuals who were infected.
Right.
Like we're just scratching the surface and understanding the impact of the virus on the brain,
Mm.
right? And the impact of hypoxia, which the virus causes,
Mm.
the impact of being in a medically induced coma for a month,
Right.
and the impact in the ICU, and no contact with family members. So that's a whole nother group of individuals that are going to need mental health care as well.
Yeah. So in a way, it's not to you or me, but it's the hidden epidemic or the hidden pandemic in all of this.
Exactly,
Yeah.
exactly. And it's typical that that this is the last thing that policymakers and funders and so on think about. But again, long after the pandemic is over, the mental health consequences will continue.
Exactly. And if you think about unemployment, livelihood being affected, the impact on both health and mental health, which then in turns affects the economy and productivity, right? There's a direct connection there. But I think, yeah, that's why I'm speaking to you and I like talking about it because I think it's important to bring that to light.
Right, exactly.
Yeah. Now, final question. What is your advice from either lessons learned or the projects that you have worked on to date for other psychiatry stakeholders or those supporting vulnerable groups, whether that's through social determinants or civil society, nonprofit work? What are the important things that you've learned as a leader to cope during this time and to lead during this time?
Well, I think the first thing is safety. For yourself as an individual, your family, and then your colleagues, coworkers. I think that's critical because this is a unusual virus, and for some it can be quite deadly. So safety is top priority. Um, and then I think it really is to support each other, checking in, utilizing Zoom and Zoom calls and Zoom meetings, but Zoom parties or social gatherings. I think things like that, and also, I think what has been very interesting to me, but I guess you see this in pandemics, but I didn't think that um, I would see it in kind of the mental health, but people in these crises, people will come together and they will be very innovative. And the system in these settings will allow for innovation to move forward rapidly.
Mm.
So there's opportunities to innovate and then learn from that, and then to um, really think about developing new and better systems to care for our patients and to care for ourselves. And so I think that part's actually really exciting to me, that we were able to test models that we'd been talking about for years, but there was tremendous resistance, and then we implemented them in days
Interesting.
as a result, because people rallied together. Oh, we have to do this, and so on.
Mm.
So as always, there's a lot of bad stuff that comes from this, but there's also a lot of good stuff that can come from this too, and we can think about healthcare and mental health care in a different way
Mm.
than we thought before. and develop new systems that are more effective, and reach more people.
Yeah. Look, I think I've heard the phrase like the best inventions were mistakes or errors, right?
Yeah,
So
exactly.
anticipated. Yeah.
Exactly.
So perhaps that's the case. Dr. Henderson, thank you so much for speaking with me. I think your perspective is invaluable and I appreciate you taking the time.
Great. Thank you.
Thank you, Dr. Henderson, for joining me. Now, let's get clinical. Two things stand out to me from the interview with Dr. Henderson. First, the quick conversion to telepsychiatry and how that affected access. And second, racial disparities in the time of COVID-19. On the first, you heard Dr. Henderson say that in 2 days, his department quickly pivoted to telemedicine or telepsychiatry, and the no-show rate significantly declined, implying that telemedicine can increase access to care and potentially reach more people, which is ever so important in vulnerable populations who may be disproportionately affected by health and mental health issues, as well as the COVID-19 pandemic. Although the consequences of this pandemic are far reaching, innovations and new, more efficient workflows and processes can emerge out of times of adversity. On the second, racial disparities in the time of COVID-19, you heard Dr. Henderson articulate how, in this time, underlying health disparities, which already exist, are further amplified by the pandemic. And we need to continually be mindful of how to support our most vulnerable and make them a priority. This, in turn, down the road will help our economy if our workforce, all members of society, are healthy and productive. I so appreciate hearing Dr. Henderson's perspective and the continued work that he does to support the most vulnerable populations in our society. I'm Dr. Allie Sharma. Thank you for watching Coping with COVID-19.